I got that one online, Brianna. I got that one online.
Yeah. Okay. What we've talked about, I know there's a lot, but, if I've talked about it. Is there anything particular you wondered about?
Like the bubble.
The what?
Isn't it bubble something?
Bubble.
Yeah.
Yeah, you got to know that. For the exam, to assess the mom. Right. Yeah. And that's easy, right?
When did we go over that?
Bladder, bowel,
breast, start from the head and go down. Uterus, where the fundus is.
bowel, and bladder.
Bladder, bowel. And then L is for
Logia.
logia, and E is for
Episiotomy.
and H is for
Homan sign.
woman's sign, and E is for okay. Yeah, you need to know that because that's how we remember how to do it.
When did we do that?
Yes, we did.
Yeah, we did it on the board. She wrote it out.
Is that the issue? What? Is that the issue?
Her eyes were open, but her brain was asleep.
Now, that's where I went through the assessment. See, hopefully you did that in clinical, right? Yay, way back.
She did it on the board the other day, too.
Okay, any other questions? Okay, well, we're going to talk about our preterm infants. My group was fortunate to see a little bit of high-risk nursery on Friday, so that was exciting. We got to look at our high-risk babies. So, what we consider high-risk infants are those, according to their birth weight, gestational age, or just predominant pathophysiological causes, right? So the first high-risk newborn infant is our IUGR, and that stands for intrauterine growth restriction. Okay? And so that means for some reason they did not grow the way they should have in utero. Okay? And this can be several different things. Typically, we'll talk about that. So what that means is the rate of growth does not meet the expected growth pattern. These babies can be term or preterm. Doesn't necessarily have to be a preterm baby, although we typically see our preterm babies are smaller, right? So, anybody know any twin pregnancy moms? Sometimes one baby. You had twins.
Yeah.
Awesome. Or you were a twin.
No, I had them very early.
Very early.
24 weeks.
24 weeks. Wow. So they were in the NICU for a while.
Yeah.
How are they doing now?
They're great. They'll be 6 on Saturday.
Awesome. Were there? Did they have differences in size?
They're identical.
They're identical.
Yeah.
Yeah, that's really early. Really early. But where did you have them at?
Levine. They had to be down there.
Levine.
Yeah.
Okay, but did you deliver? Where did you deliver?
Down there. Like
Oh,
I
you
was
did?
there.
Oh,
and
they caught
took
you in
them.
time. They caught you in time.
Well, we had a lot of complications. They had some to twin transfusions.
Oh, wow. Okay.
Yeah. And then, like I said, they got tangled. And then they took them really, had to take emergency
Oh, good. Because those initial resuscitative measures are so important. They make a big difference. We'll talk more about those. So that can be because of multiple gestations, like our twins. If mom had high blood pressure, baby's not getting as good a blood flow from the placenta, so that can be a risk factor. Smoking, again, smoking interferes with baby's growth because, again, they're not getting as good a circulation from the placenta. Diabetes mellitus and gestational diabetes also. Use of teratogenic drugs. Placenta previa, remember what that is? Where the placenta covers the surface. And congenital malformations. So that's some reasons that our baby might not get good circulation from the placenta, which can cause IUGR to occur. With our SGAs, that stands for small for gestational age. These infants are usually short with a small head circumference and have reduced brain capacity. So the difference is intrauterine growth restriction is somehow their growth is restricted. Our SGAs, sometimes we don't know exactly what causes them to be small for their gestational age. They are at risk of asphyxia because they have been in a chronic oxygen deprivation state in the uterus. Exactly. And what happens when babies are stressed in utero? What happens? Do you remember what happens? Meconium. Okay. So they release meconium when they are deprived of placental blood flow, and that due to the hypoxia, they will release meconium. So then there's the concern of aspiration of that meconium fluid. They have problems with thermoregulation, and this is due to the decrease in subcu fat or the brown fat. And also, these babies tend to not keep the flex position. They're more froggy-like, okay? So they lose temperature from not keeping flexed. Hypoglycemia occurs with these babies. So the increased metabolic rate due to heat loss, so it's kind of multi-factor, right? So they're trying to warm themselves up, increasing their metabolic rate, uses up their glucose, and then they have hypoglycemia. And they don't have the glycogen stores that are full-term babies, or our average for gestational age babies. They also have polycythemia. What's polycythemia? Right. And that's again due to what? Oxygen deprivation, just like our COPD patients. The chronic hypoxia in utero, they're trying to compensate, so they increase their production of red blood cells to try to compensate for that hypoxia. These babies we tend to see more congenital anomalies with, more infections, and cognitive difficulties. Then we have our large for gestational age. And these also have some other problems because of their size. They're more likely to have birth trauma if they're delivered vaginally. These babies are babies that are above the 90th percentile at any gestational age. And of course, they're at risk for having a C-section. What causes them to be large is diabetes in the mom, either gestational or regular. Some babies just have the genetic predisposition to be large, right? You inherit these genes. Multi-para moms, multips I call them for short. Multi-para moms, which means they've had more than one baby, right? You tend to get bigger babies each baby you have. Males tend to be bigger, makes sense. And then some cardiac issues like transposition of the great vessels can cause babies to be large. So if these babies are attempted to be delivered vaginally and the mom's pelvis is not adequate, what do we call that? You remember that? CPD. CPD, cephalopelvic disproportion. So the pelvis cannot accommodate the size of the baby's head. So it's cephalic.
Cephalopelvic.
I'm sorry?
Cephalopelvic.
I'm sorry?
Is that what you were saying? Cephalopelvic.
Disproportion. So the cephalus, the head, and the pelvis are disproportionate. If these babies are born, they sometimes, or they have a higher risk of being breached, which will give them an automatic C-section, or shoulder presentation, because their head cannot engage down in the pelvis. If they deliver, does anyone know what they're at risk? Something we check with shoulder dystocia, exactly. So they can have fractured clavicles if it's very hard to get that baby out. So we need to definitely assess for those. And how do we assess for fractured clavicles? Just feel it. Right. And what will it feel like? It's fractured in the bone. And it'll feel crepidous. So we feel for crepidous. Okay. You'll notice that baby's arm isn't moving really good. It's just kind of hanging there. And there's really nothing we can do. We can't cast that clavicle. Put that clavicle in a casket. It will heal on its own. So that's what we tell our moms. What we do is just support the arm, because when the baby moves the arm, that's when they're in pain. So you just kind of put it underneath the blanket, swallow them, and support that side. But we definitely need to check those clavicles for that. With our big babies. They're also at higher risk for facial paralysis, hematomas, and all this is due to the trauma. These babies are also commonly have hypoglycemia, so we monitor the blood sugar on our small for gestational age, our intrauterine growth restriction babies, and our large for gestational age. And again, they have polycythemia, and their blood is hyperviscosity. So it's thicker because of the increase in red blood cells. For infants of our diabetic moms, our infants of our diabetic moms tend to be larger babies, so they can fall into the LGA / infant of diabetic mom. Due to the fluctuations in the blood sugar, there's lots of problems. And the key is for mom to have good, tight control of her blood sugar during pregnancy between 100 and 120. But even if with tight control, we tend to see these babies that are larger. And the hypoglycemia is attributed to they're continuously producing insulin to combat these fluctuations in blood sugar, namely high blood sugar. And so after birth, they're still used to producing all this insulin. And then they're taken away from that sugary mom blood, so they tend to bottom out. So we need to check their blood sugars, and each hospital has a protocol. Novant had a really cool poster made up that we got to see this last week that was really great because it was like this and this. So they monitor those blood sugars really carefully. And it just depends on your hospital protocols how you do that. Some of the signs of hypoglycemia are jitteriness, twitching, lethargy, cyanosis, refusal to eat, and if it's very, very, very low, convulsions. So does anybody remember what our low on our baby is considered? We'd like it 40 to 45, yes. Less than 40 is considered hypoglycemia. It needs intervention. Early feedings are really encouraged, but if they're unable to stabilize their blood sugar, they may get an IV of D10. So it's always good to try to get, if they're breastfeeding, get that baby on breast during that half an hour of that wait period right after delivery. So what, I should have brought my little ditty because I wrote it all down, but it's like they feed them within 30 minutes and then they check their blood sugar in an hour, within 30 to 60 minutes. I'll bring that to work. I won't expect you guys to know that. Just know that we want early feedings. So they can also have hypocalcemia, and that can also exhibit as tremors. So sometimes it's hard to tell if it's tremors from hypoglycemia or hypocalcemia. So they'll usually do some blood work on these babies and see what's going on. Diabetic moms tend to have a hypomagnesium state, and that causes hypoparathyroidism, and this affects their infants. Yeah. So diabetic moms tend to have hypomagnesemia, which causes hypoparathyroidism, and this affects infants. They also have a problem with hyperbilirubinemia, which is high bilirubin, jaundice. And why do you think that is? Because it's a breakdown. Exactly. They have more red blood cells to break down.
Liver's not mature.
I'm sorry?
Their liver's not mature also?
Correct. All newborns' livers are not as mature. Preemies are even less mature, so they have a bigger problem with that. You know, they don't get the fluid volume, typically, in the first 24 hours, especially if they're breastfeeding. We don't want to discourage breastfeeding, but there's not a lot of fluid with the colostrum, right? It's wonderful stuff, but there's not a lot of volume to it, so they can be a little dehydrated. And if they did have trauma during delivery, remember I talked about cephalehematomas, our babies who have cephalehematomas, have to break down all that additional blood, all those additional blood cells that are in that cephalohematoma. And what's the difference between a cephalohematoma and a capit? Crosses the state line, right? Capit does not. I'm sorry, capit does. Cephalohematoma does not. Yeah, capit does. Cephalohematoma does not. So we usually see their bilirubins go up about 48 to 72 hours after birth. So we'll be watching them for hyperbilirubinemia. Again, they have shoulder dystocia, sometimes from birth trauma, polycythemia due to hypoxic state that sometimes they're in. And they have respiratory distress syndrome. And you think, oh, this big baby, this big healthy baby. But with the diabetic mom, whose blood sugar is not well controlled, the decrease in the insulin in the mom causes a decrease in the lecithin, Lecithin synthesis, lecithin. And that is needed for lung maturity. So even though they're big babies, they're term babies, they a lot of times have respiratory issues because of the lack of the lecithin that they've not had to mature their lungs.
I'm sorry, can you repeat that? What's lecithin?
Lecithin synthesis. With mom you need insulin to synthesize lecithin. Okay. And so they don't have that because the mom does not have enough insulin in her system for the baby to produce this to help with the lung maturity. Yeah. So a lot of times, sometimes what they'll do is they'll do a test to test and see what the LS ratio is in the mom, in the baby, before they do the delivery to make sure the baby's lungs are mature. Does anyone know what we can give the mom to help mature those lungs? Steroids. Betamethasone. So everybody's been through OB now, right? So did some of us get that done in labor and delivery? Yeah. So that helps the baby develop that lung maturity. So they give one dose and then 24 hours they give another. And that helps things like that. Our post-mature infants. What gestation are our post-mature infants?
Greater than 42.
Beyond 42 weeks, regardless of their weight, they're post-mature. And again, the placenta is only going to work for so long. Okay? Sometimes these babies do okay, but that is the concern, that the placenta is not working as well. Okay, so they're not getting as good a blood supply. So because of that leads to hypoxia in the baby. You're going to see more meconium stained fluid, which puts them at risk for meconium aspiration. And we can tell by looking at these babies that they're post-mature because their nails are longer and their hair is a little longer. They don't have any vernix, and they tend to be peely. probably because they've lost that burns. They don't have that protection from the fluid. So they're just sitting in the fluid without protection from it. So they tend to be really peely after their delivery. With the placenta not working as well, they tend to lose weight. And again, they're not getting the good circulation, so polycythemia due to the hepatic or the hypoxic state. They don't really know, but they seem to see more congenital anomalies with these babies. They tend to have more hypoglycemia. And this is just because they're not getting the nutrition from the placenta either. And after a while of being in this environment, they deplete their glycogen stores. So they don't have the glycogen stores to use after a while. Some of these babies will be born and will have seizures, and this can be due to the hypoxic insult to the brain. So we're watching them for that. And even though these babies might be not small, they do have problems regulating their temperature, keeping their temperature regulated. And this is due to loss of or poor development of their sub-Q fat, their brown fat. They may have burned it up in utero, or it just didn't develop. Our preterm infants are those that are born at or before. So at or before 37 weeks. So a 37-week and 6 days is still a preterm baby. Not until they're 38. And there we have found that their organs are not as mature. And they just don't have adequate reserves of body nutrients. There's several findings that they've found with preterm infants. A lot of time it's higher in lower socioeconomic groups. Preeclamptic moms. Preeclampsia. Again, that high blood pressure, they're just not getting good circulation, and that could cause them to go into preterm labor. It could be that they get a maternal infection. That's why we want to really monitor our moms when they come in, checking their urine, right, making sure that they don't have a urinary tract infection. So a simple urinary tract infection can cause preterm labor, as you probably remember. Of course, multifetal pregnancies puts them at risk. Incompetent cervix. Did you guys talk about incompetent cervix? Okay. And sometimes you don't know that until it's too late. Placental accidents or placental abruptions, right? Or previous that break loose. More, I would say more abruptions with this. Because with ultrasounds, we're finding out the previous early on. So this is attributed to 2/3 of the infant deaths that we have. And there's a lot of ethical dilemmas when you're dealing with a preterm baby, whether to rescue that baby or not. So that's a whole other ball game. We keep backing down. Used to be 24 weeks was kind of the cutoff for, saving babies. And now it's down to like 23. Anybody know of any younger babies that have been saved? That's the last I knew, but they keep backing down. And we'll talk about all the problems that they can have. So that's why it's kind of an ethical dilemma. Brittany, have you seen any smaller than that? You don't keep, yeah, but they do try to ship the mom and baby. Yeah. 24 weeks is your cutoff. 24 weeks at Northeast. Who should make the decision whether the cost of the resuscitation is justified and the benefits outweigh the burdens in relation to quality of life. So it's a sticky situation. So they can have a lot of cons. One big one is respiratory problems. The lungs are not fully mature, and they're not really ready to take over the process of gas exchange until 37 to 38 weeks. So that's why it's kind of that gray area.
Not ready to take over.
Not ready to take over the process of gas exchange, breathing on your own.
And what were those weeks?
37 to 38 weeks. Until 37 to 38 weeks. They have a decrease in surfactant, and that keeps those lungs from sticking together. And we'll talk more about what they can do with that. They can give the baby surfactant through an ET tube. So without having the surfactant, there's a greater chance of the lungs collapsing, becoming, they just stick together. Obstruction of respiratory passages. They also have a weak or an absent gag reflex. So you may see respiratory distress or apnea, and what is considered normal apnea? Less than 15 seconds. Greater than 20 seconds is what we may see in our preterm babies, is considered apnea. So you may have a baby when they're born, they're nice and pink and crying, and then slowly go down the tube because they're not able to do everything they need to do to keep breathing on their own. So they may be pink and just start to get cyanotic. What you're going to see, and we saw this in our baby in the nursery, retractions, so they're breathing hard and they're pulling, trying to get that air moving through. Nasal flaring, and they'll make a little grunting sound, trying to get that air out. Different types of oxygen. Babies will either have oxygen nasal cannula, but typically when we're stabilizing our babies, they're under oxyhood. And the oxygen is warmed and humidified. They can also be put on a ventilator. So surfactant is administered before 34 weeks. Not enough surfactant is produced. So, depending on your facility, do you know, Brittany, about that? No. What age they typically do that? They will put the surfactant in during, so the baby will be delivered, the endotracheal tube down the baby's throat, into the lungs, and they'll squirt that surfactant in. Did your babies get surfactant?
I can't remember. I did. One of my friends had real bad lung issues, so like they were just not mature enough.
Yeah.
But it did come around, but he was on oxygen for like 3 months after he got home.
Yeah, and we'll talk about what that was probably different due to. Okay. So that has been a wonderful thing to be able to give these babies surfactant. It really helps their progression and prognosis. Typically before 34 weeks. But if a baby comes out and is having respiratory distress, they may do it. It just depends on their facility. They may try it. But they found that at 34 weeks, they do produce surfactant. So before that, they need it given to them. So as I said, we don't typically do blood pressures on our newborns, but our preemies and our sick babies, we do. They tend to be hypotensive, slow capillary refill, and we suspect that it's a cardiovascular issue if they continue to have respiratory distress despite giving them oxygen and ventilation. This can be due to a patent ductus arteriosus, and we'll talk more about that in a minute, but it's decreased pulmonary arterial musculature and hypoxemia causes that. So decreased pulmonary arterial musculature, the muscles in the pulmonary arteries are immature, and hypoxemia causes that patent ductus to not close. Another big problem, of course, is thermoregulation. They have a large surface area in relation to their body weight. They don't have as much brown fat to keep them warm, and they don't have as much sub-Q fat. They don't have the normal reflex that controls the skin capillaries. Their inadequate muscle activity, they tend to be our little froggy babies. They don't tend to keep flex, which helps with their temperature control. And again, they don't have the muscle tone. They're just, again, froggy babies. They do not have a shiver response, even as newborns do not have shiver response. So they can't protect themselves from heat loss. And they have even a more immature temperature regulation center in the brain. So these babies, once they're stabilized, they'll be on the radiant warmer initially. And then once they're stabilized, we have to help them keep warm. So they are in a warmer or an incubator to maintain their temperature. And we have to make sure we don't overheat them too. So we want to monitor their temperature very closely because they can very easily get hypothermic. And if they get hot, they're going to use more oxygen to try to cool down, and then they're going to have more breathing problems. Other problems, GI function. If they're less than 34 weeks, they may have to get a gavage feeding, and we'll talk a little bit more about that in a little bit. And this is because they have a very weak or an absent suck, swallow, and gag reflex. And so initially our preterm babies may even get perennial nutrition, TPN. Because what happens if they're having a lot, problem keeping their respirations going, we don't want them trying to bottle feed, burning up their calories, and, it can cause them respiratory distress just trying to keep their, trying to eat. Burns up a lot of calories and, can cause them to have more respiratory problems. So especially if they're having respiratory problems, we won't bottle feed them. They usually get an IV initially. Renal, their kidneys are not able to excrete drugs, metabolites, concentrate their urine. They have a problem with fluid balance, so we need to really monitor their I&O. We need to make sure we're checking for any bleeding from any puncture sites. So what do we give our newborns? Because they don't have the ability to clot blood at birth. Vitamin K, right? So these babies have even a more immature liver, so they need definitely to be watched for bleeding. Infection, they of course don't have the immunity that our newborns have. Our newborns don't have a lot, as it is, but our preterm babies have even less, so we need to make sure good hand washing. They didn't let you guys go into the nursery at Northeast because of risk for infection. They were worried about that. And we got to be really careful with their skin. Their skin is very fragile, so they're kind of like little people where their skin just kind of tear off very easily, so we have to be very careful with any adhesives, and we don't use any skin products on them. So there's a lot of questions that need to be answered to determine their nutritional needs. And this is done by the doctor as far as figuring out what formula they need, whether they should be bottle fed, whether they should be wash fed, how much, they figure that out to the CCs and the schedule. Because they might not be able to breastfeed or bottle feed. As I said, due to respiratory distress, or sepsis even. So we're going to determine, we're going to be watching their pattern of weight gain very closely, weigh them every day and loss. So that might be adjusted daily as to how many cc's they will get per day per feeding. Definitely need to listen for bowel sounds. If they're gavage fed, we need to check for residual, just like we do our adults. And then you'll have specific instructions whether you return that amount if it's less than such and such. And why do we want to return what we take out?
For pH.
pH. Yeah. Don't want to mess up their electrolyte balance. Of course, monitoring their stools. And again, weight is done daily. We're also looking at the readiness to feed. Are they sucking on a pacifier? No respiratory distress? Are they able to suck and swallow? And of course, their condition. Are they stable enough? With our preemies, the best milk they can get is breast milk. So it's really great if our moms will pop their milk and give it to their preterm babies. It's so much more easily digested, especially by our preemies. But they would be getting with the gavage feeding, they either get breast milk or formula through an NG or an OG. A lot of times we'll do the OG because our babies are nose breathers. just to make sure that that doesn't give them problems breathing, we'll just put an OG in through the mouth. These feedings can be done intermittently or continuous. We always did ours intermittently, every 3 hours. And just like adults, again, you're going to check for residual and then do the feeding. One thought is residuals less than 1/4 of the feeding can be re-given to the infant. And again, we're doing that to prevent messing up the pH balance of the tummy. So here's just a little picture of the different feedings. And you measure them just like you do for your adults. Tip of the ear, the nose to the xiphoid process. Okay? Sometimes if our preemies are still having respiratory problems when they go home, they would get a gastrostomy tube. And you guys all know what a gastrostomy tube is. And typically, we're always doing our feedings by gravity, just like you do with your adults. And like I said, TPN may be administered if the infant's unable to get enough fluids or calories by feeding. So they might be getting both.
What's TPN?
Total perennial nutrition. That's that yellow fluid, that liquid gold. Gives them everything they need in fluid through the IV. You haven't seen any of that on either. Yeah. Okay, so, and what we'll do, as long as our baby's not in distress, get them to start learning how to suck. Basically, we'll give them a pacifier during the feeding, and then they'll correlate sucking with feeding, that filling feeding, and receiving or feeding, and that's, we found, helps them transition earlier to nipple feedings. We definitely don't want to overstimulate these babies. They're not supposed to be out here just yet. So we typically keep the lights low, noise level down, quiet hours. We try not to touch them any more than we have to try to let them sleep and grow. Sometimes they'll swaddle these babies. They'll have to adjust the temperature in the incubator, the warmer. Because babies do like to be swaddled. Okay. And, we don't want to stress our babies. That can put them in respiratory distress if we overstimulate them. So we need to be aware of what kind of signs we would see. And here's a view of them. A lot of times the heart rate will just drop down or speed up. So that means we're overstimulating them, and we need to decrease the stress in their environment. We're just going to do some fun stuff tomorrow. We'll recap it. I'll try to find some good videos. Just as with our newborns, skin to skin is awesome for our preemies. So a lot of times that's how they initially get the parents involved in the preemies care, is just allowing them to do some skin to skin. And of course, just like it does with our full-term babies, it helps with bonding. And they found that, again, it helps with their temperature, their oxygenation, so it's just awesome. And it's funny, my little newest granddaughter is 7 weeks. She still wants skin to skin. So, we were with them over the weekend, and my daughter said, just put on a tank top and she'll love it. You know, just put her right here. And that settles her right here. It's awesome. So it really does work. It doesn't have to be mom. It can be anybody. I just love that skin. All right. How about you take a 12-minute break, come back about 1/4 till. Any questions?